Hello and welcome to a special interview for The Wire. The B.1.617.2 lineage of the Indian mutant has caused great concern and worry in India, but it's caused equal concern in the United Kingdom. In Britain, as a result, scientists have devoted a lot of time trying to understand this mutant strain. And joining me now is someone who's at the very forefront of that study, Professor of Clinical Microbiology at the Cambridge Institute of Therapeutic, Immunology and Infectious Diseases, Professor Ravindra Gupta. Professor Gupta, last week, one of Britain's important advisory bodies, SAGE, warned the BBC that there was a realistic possibility that B.1.617.2 could be as much as 50% more infectious than the UK variant. And the UK variant, we've anyway been told, could be 40 to 70% more infectious than the original strain. And that's created a certain amount of concern in India. So my first question is, how accurate is that estimation? Let me ask you, how much more infectious do you believe is B.1.617.2?
It's a difficult thing to assess at the moment because from India, we haven't seen much in the way of mathematical modeling or even the estimates from infections in the community. Here in the UK, we have to remember that the infection started in small clusters of people traveling. So it's quite hard to estimate transmissibility from those sort of data, but people are pretty convinced that there is a moderately increased transmissibility. And I think that this is fair to say, partly because of what we're observing, but also in vitro, we see that this virus has certain attributes which enable it to cause infection more readily in cells, in particular. And so there are some biological reasons why this is a likely scenario. But we should also remember there is another important element, which is transmissibility doesn't really take into account the virus's ability to avoid antibodies that people have made because of vaccination or from previous infection. And one reason we may be seeing this virus spread more quickly is that it is better able to get around the immune response in individuals.
I'll come to the virus's ability or this variant's ability to get around antibodies and vaccines. But just for a moment to clarify your answer on transmissibility, your personal opinion is that it's not necessarily 50% more transmissible than the UK variant. You believe it's moderately more transmissible, but it's hard to be precise.
That's right. I mean, it could be as high, it could be 50%, it could be 30% or 20%. I think that the actual number is not so relevant. I think the key thing is what we do about it. And also, well, the reasons for this observation are important. As I said, is it just a property of the virus or is it able to do some immune evasion, which has different implications?
Absolutely. Let me speak a little bit to you about the situation in the UK before I talk to you a bit about India. And then I will come to this big question that everyone is concerned about. Is it more likely to evade vaccines and antibodies? But first, the situation in the United Kingdom. I noticed that for 2 consecutive weeks, cases of B.1.617.2 have doubled each week. And according to the BBC this morning, for the week ending today, Thursday the 20th, cases have actually increased by 125%. So is this beginning to become a pretty serious threat in Britain?
Yes, I believe so. I mean, the doubling rate is at least weekly, which is what you see when you have an unrestricted virus in a population. So we are seeing that sort of rise. Again, it's been fueled by potentially small clusters. So this is not a generalized epidemic yet, but I believe it will be because we started in small pockets. We now have bigger expansions in different cities. They're doing surge testing and enhanced interventions and enhanced vaccination in more areas. And this is just going to continue because we are now coming out of a lockdown simultaneously, which is, in my view, going to fuel this rise that we're seeing.
Now, initially, in fact, this particular strain, B.1.617.2, was said to have been found in places like Bolton, Blackburn, several cities in Lancashire. You now fear, particularly as you come out of lockdown, that it could become a generalized spread variant.
Absolutely. I think the probability of that is 95%, that this is a virus that is going to become the dominant virus in the UK.
In other words, is there therefore a danger that the lockdown that looks as if it's beginning to end might at some point, not so far in the future, have to be reimposed again?
There is a possibility that may happen, and which is why myself and others in the scientific community have been calling for the most recent relaxation to have been delayed, but it was not delayed. And the next phase, again, is in jeopardy. So we shall see. But unfortunately, the current easing has probably allowed further fueling of this new variant.
So your concerns as far as the UK are concerned are growing.
Absolutely. I think we're going to see a significant expansion of infections. We're going to see more hospitalizations. We will see, some deaths. And I think that has a psychological impact on the country. The numbers may be relatively small, maybe hundreds of deaths or thousands of deaths, but it will be smaller compared to before. But I think the impact on the psyche is important to also take into account.
Let's at this point come to the situation in India, which I know you also follow fairly closely. According to the Regeneron COVID-19 dashboard, it seemed that towards the end of January, just 1% of samples being sequenced were of this particular strain B.1.617.2. But 3 months later, by the end of April, that percentage jumped from 1 to 77. Does that give you a sense that perhaps this particular strain is the key driver of the surge that India is presently experiencing?
I don't think it can be blamed on the variant. I think that India has, had a complete lack of any kind of social distancing, and there were large gatherings happening since January. So even if this were a different strain, I think we would have still seen a significant surge and wave in India. But it's probably been compounded by this new variant. There's no doubt. But we can't shift the onus of what's happened onto the virus. The virus was only doing what it was allowed to do in the first place.
In other words, the virus made an already bad situation worse.
Yes.
Now, the truth is, the lineage that we're talking about, B.1.617.2, is only one of the 2 or 3 lineages associated with the Indian mutant. The other 2 are B.1.617.1 and B.1.617.3. Are they as transmissible as their sibling, or is this particular 6172 the most potent in terms of transmissibility?
I think that it's probably the 0.2 is more transmissible because it seems to be overtaking the 0.1. And so biologically, one would think that this has an advantage in some way over the other. And even in the UK, where we had both viruses introduced, the 0.2 has been the one which has taken off. Now, it's unclear as to why that is the case. The 2 viruses share much in the way of their ancestry and their genetics. There are quite a few differences. So I think we'll be focusing on those to try and figure out why. The third one you mentioned is really very low case numbers, and I think can be ignored for now.
So the UK experience suggests that 6172 is more transmissible than 6.71 because 6.72 is the one that seems to be taking off in the UK, not 6.71. And that would suggest that something similar would be the experience in India as well.
Yes, and I think we're seeing it in both countries that the 0.2 is dominating, either because it spreads faster or infects cells faster and spreads within the body faster, or because, as we said again, or it has a better immune evasion quality.
Let me at this point come to 2 critical questions that are in the minds of the audience in India as they listen to you. The first question is to do with whether 6.72 will lead to instances of worse or more serious illness. Everything that I've read, written either in the UK or India, suggests there is no clear, convincing data that it will lead to more serious illness. But is that your impression as well?
I'm getting the impression that it depends what you're comparing it to. And of course, it's really difficult to match patients infected with one strain versus another, because there are lots of what we call confounding factors in terms of who gets which infection. And, if you live in Bolton and a deprived area and you get 0.2 and you have diabetes, you can't compare that to somebody who lives in London who gets the different strain and survives, and they're an affluent person with good health. even if they're the same age. So there are lots of confounding factors that go along with the strain that you're infecting with. So it's going to be, we're not going to get a definitive clinical answer to that for a long time. I can say that the virus does appear to be causing infections in people who are vaccinated, number one. And number two, that we hear reports that young individuals are succumbing to the 0.2. On the other hand, we did see that for the B.1.1.7 UK variant and even the original strain. So you will see this happening, but it's unclear as to whether it's enriched or more common in the 617.2 viruses.
So if I understand you correctly, we don't have a clear, clinically proven, scientifically proven answer to the question, does 6172 necessarily lead to more serious sickness? We just don't know at the moment.
Don't know.
Let me then come to the question that I suppose is uppermost and the most important for audiences. And in a sense, you've hinted at that answer 2 or 3 times already. Is B.1.617.2 more resistant to vaccines?
I believe it is less sensitive to vaccines, which is a different way to frame that statement, because it's not fully resistant, because of course people who are vaccinated are still surviving. They don't get very sick. They usually have mild symptoms in the main. And that means that the vaccines are doing their job, which is to protect you from severe illness. The 617.2 does appear to be able to infect people who have had the vaccine, and it results in mild disease usually. So we've described in collaboration with INSACOG and colleagues at NCDC to describe a group of people who are infected despite vaccination in a healthcare facility. So there are credible data that show the virus is better able to get around vaccines, but it doesn't change the fact that everyone must be vaccinated even faster than they were before. So the way to control this is through vaccination.
I take it the data you're referring to when you talk about this particular strain's capacity to get around vaccines and infect people who've already been vaccinated is data that was published in a preprint paper that I believe came out last week, which you've worked on yourself along with some scientists in India, where you analyzed 33 breakthrough infections in a Delhi hospital that happened earlier this year. And your paper says, and I think I'm quoting correctly, the majority were B.1.617.2. The vaccine.
That's right.
Yeah. Although you don't mention the vaccine explicitly, but the vaccine, I believe, was AstraZeneca, which is called Covishield in India. So in addition to making the point you made that this strain can get around vaccines, does this also suggest that Covishield or AstraZeneca are less effective against this strain?
So we don't know that yet. I think that, all the vaccines perform very, very well in terms of protection from death and severe disease. Now, whether the AZ vaccine has a lower protection rate needs to be established. And we're doing those experiments in the next few weeks here. I think other people will have data sooner than us on this.
But interesting. I'm interrupting you. You are specifically working to find out whether AstraZeneca, which is called Covishield in India, has a lower protection rate against B.1.617.2. You're actually studying that specifically.
Well, we're not studying it in patients, because to study this in individuals that's a really difficult study to do. Because in India, of course, the dominant vaccine is the AZ. You may be able to study this in the UK, where different vaccines are available, and you can see how frequently people are infected. But even in the UK, there were differences in which vaccines were used for which people. So the elderly were vaccinated first and they received the Pfizer vaccine. The younger individuals have received more of the AZ vaccine. There are regional differences as well. So again, this is going to be very difficult to tease out. I think the best way to look at this will be in vitro. We can take blood from people who have had either vaccine, and then we can look at how well the blood antibodies protect against infection in an artificial system. So that's something that I think people want to do. When we published this preprint that you're quoting, we used serum from vaccinees who had the Pfizer vaccine, and we showed that the 617.1 was less sensitive than the original strain. So we need to do the 0.2 virus, which we are getting results on, and also we need to test different vaccine sera, because of course the question in India was well, what about our vaccine? You've given data on another vaccine. What about our vaccine? And I don't personally believe there's going to be a huge difference. That's why we did the study in Pfizer. But given that people want to know the answer, we're doing those experiments.
Just so that the audience understands that in vitro, that means you're going to be studying it in a petri dish rather than actually through human beings who've been infected. Is that correct?
Yeah, in vitro in the lab.
And when do you expect this study to be completed by? When can we expect to know the results or the outcome?
Well, for us, it's going to be at least another 2 or 3 weeks because we have to recruit new individuals being vaccinated. But I think other people in other countries and other places will have data sooner than us on the AZ vaccines.
But your results, testing in vitro, whether the AstraZeneca vaccine is less sensitive to this particular strain, will be known in 2 or 3 weeks' time.
Yes, and I think we will have a very good consensus on what's going on.
Let me at this point broaden our conversation a little. There is a lot of concern, or maybe the better word is there's a lot of criticism in India, both about the quantum of genome sequencing being done, as well as the speed at which it's done. And as you know better than me, it's only effective, regular, frequent genome sequencing that can identify variants as they emerge and give the government or policymakers a chance to take action to check them before they begin to threaten the country as a whole. Do you share those concerns and criticisms about the speed and quantum of genome sequencing in India?
I've commented on this to other sort of people. Obviously genome sequencing is great and it is a bit of a luxury. It doesn't really change what you do. I mean, it tells you have a particular strain, but at the moment we only have 1 or 2 ways of combating SARS coronavirus 2. One is social distancing and lockdowns. Number 2 is vaccines. And then we have a few drugs to treat it. None of those things are impacted by the variant because the policy outcome of expanding cases is always the same: vaccinate and social distancing.
In which case, let me ask you this. There is a story that Reuters put out, I think it was on the 1st of May. It was then corroborated to me in person by one of the scientists involved, Rakesh Mishra. He used to be, in fact, the director of the Center of Cellular and Molecular Biology in Hyderabad. And the story was a simple one, that INSACOG, as far back as early March, had forewarned the government that there was a rising incidence of new and more contagious variants of the virus, and they were worried about potential exponential spread. And that advice formally delivered by INSACOG was ignored because Kumbh Melas continued, political rallies continued, and in fact, ministers like the Home Minister and the Prime Minister not only encouraged crowds to come out, but the Home Minister went on record to say that rallies don't affect the spread of the virus because I'm in Bengal where it's not spreading, it's only happening in Maharashtra where there are no rallies. And as a result, the response of the government seemed to disregard and ignore the scientific advice they got from INSACOG. Does it worry you when governments almost deliberately disregard their own scientists?
Well, I mean, it does worry me, but then again, it's happened everywhere. It's happened in this country, the UK. We're already having the same situation all over again, where the scientists are saying slow down and they're not doing it. So this is a problem many countries face. I think, it's a sign of good leadership to be responsive and do the right thing quickly, and obviously use scientific knowledge to inform policy. I mean, there are countries out there where there's a lot of misinformation. We've heard things about the Brazilian president. We heard things about, countries in Africa where there's denialism. India should not be one of those countries. We are an educated people, and our politicians need to be educated as well, and do things in the interest of the people. And that's clearly not been happening in India, which is sad.
So as a scientist who studies these variants as they come out and knows their characteristic and therefore understands the threat they pose, you must have been particularly distressed when the Indian health minister, who incidentally is a doctor himself, said on the 7th or 8th of March, we're in the end game. Or when the Indian Prime Minister declared to the World Economic Forum, we've effectively seen off coronavirus and we've shown the world how to defeat the virus. That must have particularly distressed you because you would have said to yourself, these are bizarre things for politicians to be saying.
Yes, I mean, we all wanted to be very positive and about why India had been spared, the kind of death and mayhem seen in other countries. And I was also very curious as to why things had settled down. But clearly, that was incorrect. And, the early declarations of victory, of course, would have completely ignored what was happening in other countries. And this is something I can't understand, why people think that they're special. We're all human beings on the same planet with the same ancestry. We're not as different as our faces will make us believe. So when something happens in one place, you bet it's going to happen in your own country. If not today, it will happen tomorrow. So that's a take home.
Now, another problem that people face in India is that we are told very little, and sometimes I might add, if anything at all, by our own system. It's almost opaque in terms of discussing and revealing details of B.1.617.2. Whatever information we have has to be either painfully teased out at press conferences from fairly reluctant bureaucrats, or it's gathered through reports from the Western media where people like yourself are being quoted because of the work you've done in Britain. Given the potential threat this strain poses India, do you think the Indian system should be more forthcoming, more open, should let the Indian people know the nature of the threat they face?
I mean, yeah, I do think that. I think a proper public engagement system is necessary in India, if not for this pandemic, for future things, because there is a lot of misinformation in India. We've seen that, a lot of rubbish on social media platforms, etc. And really the government, of course, there's obviously mistrust of the government, so there may be a problem there as well. But I think that a concerted public education campaign and communication campaign will certainly be in the government's interest in terms of gaining cooperation for further restrictive measures and also for vaccination acceptance. So I think that is a big hole in the Indian response to the pandemic. And other countries such as the UK have had better public communication. They've had regular press briefings, etc., where scientists, heads, very respected scientists, have come and given their analysis of the situation. I think something like that would be very important in India. I'm going to have to go now. Sorry.
Very, very quickly, one last question, if I may. You've worked on the B.1.617 variant. What advice would you give the government in India in terms of steps and measures they should take over the next few weeks and months?
Well, I think that obviously stepping up vaccination is critical. I think that limitation of social gatherings, of course, is essential. Some weeks ago, I mentioned that a lockdown was probably necessary at a national level. I know that certain cities are already in lockdown. I guess I don't have any further advice except for further investment in detection, treatment, and of course, social communication.
The government issued an advisory literally hours before we went on air to record this interview. And one of the things they said is that they believe aerosol particles can carry the virus up to 10 meters. Now, that's not something new. It's been known about for a while. But the government chose today to emphasize this point all over again. And so the strange part is, having made the country aware of something we probably put to the back of our minds, that aerosols can carry at 10 meters, they haven't told us what to do. So let me ask you, is it really the case that at a distance of 30 feet you can be infected by the virus? And if it is, what on earth do we do to protect ourselves other than make sure there's no one even within a mile around us?
Well, I think that, yes, the way to protect yourself is to be vaccinated, of course. So, that's the most important thing. If you're vaccinated, you won't die from that disease from being near someone. The second thing is, of course, wearing a mask if you're vulnerable or in a risk category, even if you've had your vaccination. So I think just being cautious and about your surroundings and who you're mixing with, and being vaccinated with both doses is vital. That's the take home.
The government also stressed that there's a need to frequently, those are the precise words, clean door handles, light switches, tables, chairs, and floors. And they even suggested it be done with bleach. Now, just a month ago, CDC in America said that there was less than a 1 in 10,000% chance of actual infection through surfaces. Is there a need, because of this variant, to frequently clean with bleach door handles, light switches, and even the floor?
I certainly have stopped doing the surface cleaning because it's not sustainable. But I think that if it raises awareness, I think there's no harm in it necessarily. So I think that increased awareness is important, and the aerosol route is probably more important. The surface thing is probably less important, but it could still happen. I'm not sure you can actually measure this properly scientifically, so I don't know where the US estimates have come from. So I would say not necessarily to focus on that, but as I said, vaccination and social distancing is key, and wearing masks in public places.
Double masks as well?
No, I'm not really.
Not double masks. Okay, I know you're in a hurry. I want to thank you for having spared time for me, Professor Gupta, and thank you in particular for having shared with us what you know about B.1.617.2 and the fact that hopefully in 2 or 3 weeks you will have a clearer, better answer whether the AstraZeneca vaccine is less sensitive to this particular mutant. Thank you very much indeed. Take care. Stay safe.
Yeah. All right, you too. Thank you.